So we're going to talk about Varda5.
Yes.
With Andrea Shields. I guess, Andrea, how did your journey get to CCI and ultimately Varda and Obstetric Life Support?
Yeah, I'll take you back. So it all started actually from a personal event. So I had a twin pregnancy. It was high risk. And shortly after having my twins, I was taking care of my kids, and actually one day I started having some really bad chest pain. And eventually I got diagnosed with something called spontaneous coronary artery dissection, which is a form of a heart attack.
Wow. Oh my goodness, how old were you?
This is back in 2000.
At the time.
I was in my mid-40s. No, I was actually in my was it mid-40s? No, it was early 40s. And so not a thing I ever thought would happen to me, because I was very active. I was a runner and very fit, didn't have any family history of cardiovascular disease. And
that's terrifying.
Yeah, it was pretty terrifying. I thought it was just bad heartburn, which is typical for women, right? Like when they present with heart attacks. So I got through that event, but what I found particularly alarming was the amount of people who didn't know anything about what was going on with me, because they tried to apply all the treatments and all the diagnoses of like somebody who is 80 or 90 years old having a heart attack. And so this particular form of heart attack is where the blood tracks through the vessel wall in the heart vessels, rather than, a typical, event for somebody older would be something called a ruptured plaque, where you get a clot there. And so it took a long time to get to the right diagnosis, and a lot of research on my own part. Being a high-risk obstetrician, I was researching a lot while I was trying to figure out what was going on with myself. So, fast forward, I really wanted to understand why this was happening in women my age, and I wanted to look deeper into the statistics. There wasn't a lot about it at the time. I was talking a lot with my doctor, who's one of the international researchers on it, and she had happened to tell me, this happens a lot in pregnant and postpartum women, and it's one of probably the main reason why they have heart attacks.
Did having twins have anything to do with it, or no?
Yeah, I mean, there's some risk factors. So having twins inevitably makes you higher risk for most every condition in pregnancy, but they don't know exactly why SCAD happens. SCAD is the short term for it. They think there's some predisposition, with extreme weather sports, type A personalities. They have a lot of lawyers and doctors who have had this kind of event. But yeah, they're still working out, I think, the risk factors, if you will. But really, it comes down to people who have very little risk factors who end up having this. So it's almost a diagnosis of exclusion, where you're working backwards.
Yeah, I mean, that's really hard to have any predictive information on it if it's
right,
people
exactly.
who typically wouldn't have a heart attack.
Yeah, absolutely. I was alarmed because I had not really heard a lot about it, and I had been taking care of high-risk pregnancies for so long.
Yeah. Being in the space and not actually.
Correct. Yeah. So I thought if I had all this training and didn't even know about it, then how many other people don't know about it? And really, in general, cardiologists at the time where I had my event didn't really know about it. It was one smart Argentinian hospitalist who said, you need to go to Mayo Clinic or Cleveland Clinic and figure this out. And it was ultimately Mayo Clinic that diagnosed what was going on. Like I said, at the time, I think there was very little information. Now they've accelerated and we have quite a bit of information on it. But that's initially what started my interest in the cardiovascular space. Okay. And as I learned more and more about this, it was around the same time that ProPublica and other outlets started to publish on the rising maternal mortality rates in the country, which we didn't think was a problem, but we certainly know now is a huge problem in the United States. And so the reason those are linked is because 2/3 of maternal deaths in our country are because of cardiovascular conditions.
Oh my goodness.
Yeah. So that was where our interest started, and it was really about awareness and advocacy initially, but it turned into something much larger than that along the way.
So the business model, so to speak, it's training for providers. Is it group sort of focused, or is it is it type of facility focus? Like what's your approach
great
there?
question. We really had to take a step back and say, like, where is the problem? Why are pregnant women dying, postpartum women dying? And it's really, if you look at the system, like that's taking care of pregnant women, it was happening in all trimesters, although we now know it happens a little bit more now postpartum in the first year after delivery. But it was also happening throughout the chain of survival. We call it the chain of survival. So we had some women who were going down at home or at events, all the way through to, becoming sicker in the hospital and then needing the care there. So we knew we had to tackle this problem from all dimensions, if you will. And so we started developing an educational course that worked for EMS providers, so paramedics, EMTs, all the way through to like critical access hospitals, maternal transport teams, and to level 1 and 2 facilities, which kind of are the lower resource facilities in the country, as well as the most highly resourced facilities, which are level 3 and 4 levels of care. So we really took a very broad start to developing the course or courses for all of these groups of people who all have different experiences and different levels of training. And so I had to bring in experts from all of those walks of life, which was very cool because I hadn't worked a lot in the pre-hospital space with paramedics and EMTs. And so I got to kind of know what their world was like and what their experience was like. And we started to see right away that there was a huge gap that really our field in obstetrics had never looked at.
Probably something that they would never even kind of consider, like, the EMS training is probably so much more like just like blunt, kind of like,
keep alive.
Field of battle type, keep them alive. Right?
They have like 16 hours of what they call special population training. And, this could be everything from from pediatrics all the way up, to pregnancy care. But it's interesting because, they're probably my group who's the most wide-eyed when they take the course because they've had very little exposure, but they'll all tell you they're terrified when they are called to, a scene where there's a pregnant woman. Terrified. It's because they're not prepared.
Right. What about when my wife was pregnant? We have twins.
Great.
What's the course that you go through, like before the kids are born?
Are you talking about like Lamaze?
Yeah.
Yeah, like childbirth education classes.
Yeah. Did you do that at all?
Yeah. Well, I mean, Tori's very type A, so we did all of the courses.
Yeah. But the point of me talking right now is like our women, the fathers, partners, are they educated about the signs and symptoms early on?
Yeah, that is such a great question. We're actually developing a course for that.
Oh, great.
Yeah, as part of an offshoot of this, because again, like you're correctly identifying, I think there's prevention, piece of this where people who are supporting a pregnant person going through pregnancy and, that for certainly that first year of life might be able to recognize things to raise the alarms on. Oh, yeah. Whether it's the spouse or the partner or the community worker, the doula.
It's just, maybe because it's recent, but it just seems like the entire system is flawed with pregnancy and with because I remember she just gave birth, right? And it's like, all right, we'll see you in 8 weeks or whatever. Like there's no checkup for the mother, right? It's like you're getting all these these tests for the baby, and then you give birth, and then it's just like, all right, well, see ya, right?
It was different in the UK.
Was it?
Yeah, because we lived in London for a while, and the girls were born there, but we had a midwife come every single week to check on her and the kids.
Oh, well.
Yeah, there's a lot more community worker involvement in other countries for sure. And I think that is one place we have a lot of work to do here. We call it the 4th trimester now, right? You give birth, and now I had a mentor who unfortunately passed away who was involved with a lot of this initial work. And he always used to tell me the analogy would be it's like the candy in the candy wrapper. Like the baby's the candy. The babies are the candy. And, after birth, the candy wrapper gets thrown away. And it's unfortunately the truth. So much in our country has, especially in that first year after delivery, has really ignored the pregnant person's journey. And that's the time when, I don't know if you know this, but mental health becomes a huge issue. And, my training was very limited around that. Now I think there's a lot more emphasis on really recognizing and screening for depression and anxiety and psychosis, and at least understanding how to initially treat that or treat more simple cases, because there's a dearth of mental health providers in the country to get people to. So they're trying to train obstetricians, pediatricians, family practitioners how to take care of it.
It seems like it still puts a lot of the onus on the mother, though, like to even self-diagnose to a certain extent, or like see that, or feel something specific. And, there isn't as much of a cadence to sure, you go and you take a survey and it's like, okay, I'm going to, answer however honestly, but like there's really very little independent conversation or assessment, it feels like.
Oh, for sure. Yeah. And, like I said, there's a lot of research being poured into this now, which is one thing, pregnant women have been left behind in research because they were excluded for so long.
And why? Like what
just because the physiology and the anatomy are different in pregnant women. And so when you're looking to make a population as homogeneous or as the same as possible, including things like, people less than 18 or pregnant women, even like people who are jailed, like it's easier and it's quote unquote cleaner to exclude them. But there's been calls in the last, I would say 10 to 15 years to not do that anymore, to include them in groups because they're just important to understand, So a lot of what we do as obstetricians is we try to filter the data that's out there, the evidence that's out there, and try to decide whether we can apply it to pregnant women or not.
Unfilter it.
Right. Yeah, it's really frustrating. But we're trying. As a researcher in that space, we were really trying hard.
And so how are you trying to get them in terms of the training, it has to be person to person, I assume?
Yeah, so it's an instructor-led course. Yeah. So our participants do 2 to 4 hours of online work before they come to the course. And then we try to make it as interdisciplinary as possible, because one thing that, happens along the way in medicine, it's very easy to train all the same people at the same time. So all nurses or all residents or all doctors, of one specialty. But if you have a real world emergency, that's not who arrives there. Who arrives there is a team, a multidisciplinary team that could be anesthesiologists, obstetricians. You might have internal medicine. You might have an ER doc coming up from downstairs. You might have a general surgeon. And so we wanted to really replicate what would a rapid response team look like that was coming to the emergency. Yeah. And, we try to make it as interdisciplinary as possible. And that was a really important tenet of ours, just because we wanted to be as real world as possible in the simulation environment. So we try to get a varied participant, specialty background, nursing doctors to sign up for the courses. And then they come in and an instructor will take them through the course. And it's usually about 6 to 8 hours. And we go through scenarios that we developed with, we had about 35 experts from around the country and Canada who are all in this space, doing research in the space. And then we adopted some of the more progressive and evidence-based simulation technologies and methodologies for teaching.
And so the people that are getting taught and instructed, it'd be interesting to hear the feedback and understand, what was being taught to them received as net new information, the treatment, was it all net new? How much of it was a surprise to?
Yeah, so I can give you a statistic that might explain that. So most of these nurses and doctors had received certification in something called Advanced Cardiac Life Support, which I think up to this point people had thought was adequate to take care of a pregnant woman. So everyone had to be ACLS certified, to work on a unit or do postpartum recovery after a C-section, things like that. But when we actually did a randomized trial where we blinded our instructors to the teams that were going in and handling a medical emergency. And what we found is that less than 10% of the teams that never took our course could actually do the resuscitation correctly. They could not respond to a medical emergency that led to cardiac arrest the right way.
Why? What is the physical difference?
Yeah, so we standard CPR doesn't work because of the changes. So what's happening is, you're getting rapid growth in organ systems, probably the uterus, right? The uterus that contains the baby. That in turn causes compression of the aorta and the vena cava when somebody's lying flat. And to do proper CPR, you have to be lying flat to get good chest compressions.
Right.
And so it effectively makes chest compressions ineffective because of the compression on those vessels. So you don't get the blood return to the heart that you need.
Right.
So the only way to counteract that is to actually displace the uterus off. So we teach something called left uterine displacement, where, we're actually showing them how you get the uterus off the vessels during CPR. And that increases the cardiac output by about 25%, which can, lead to
right. Wow.
Basically an unsuccessful resuscitation if you don't do that. And so that was where most of these teams weren't doing that, or they were trying to roll her, which is like the old way they used to teach it. But then once you roll somebody or wedge them, then chest compressions don't become effective because you're not you don't have like that hard space in the back, and you're not doing them in a perpendicular fashion. The other thing is that we know evacuating the uterus in effect has the same end result. So it allows the uterus to decompress, and you're getting more blood flow back, but it also causes what's called an autotransfusion. So it puts blood back into the system, about a liter of blood when you do that. And so we recommend, if you're 20 weeks or beyond, when you get that compressive effect, to actually do a cesarean delivery by 4 minutes into the arrest. So once you lose a pulse. And most teams, again, didn't know to do that. They were using maybe like the fetus as their guide, and we really don't focus on the fetus in that moment. We focus on mom, because if we can resuscitate mom, then the fetus will do better.
Yeah.
And so, in effect, those two critical elements, and they've been published since 2015, nobody was doing.
Wow.
So even though they took ACLS classes, they still didn't know that we needed to modify for pregnant women. And
that's a pretty fundamental difference in understanding, right?
Correct. Yeah. I mean, there's a lot more to it, but those are the big ones.
Yeah.
Those are the big ones. I think like just the framework of why would a mom have an arrest is very different when you're walking into that room versus somebody who's a female who's 80, let's say. They're different reasons. And
what did people what was the diagnosis typically?
Yeah. So, I mean, the most common one, other than mental health, right? So overdose, suicide attempts, things like that. So putting that aside, the most common ones we tend to see are things like heart attacks, cardiomyopathy, where you get a dilation of the heart at the end of pregnancy or postpartum. You can also have what's called a pulmonary embolism, which is a blood clot that develops in the lungs and goes to the lungs, a pretty big one, can be catastrophic. We still have a lot of people in the country, unfortunately, that are suffering from hemorrhage. So either around the time of delivery or after, and they can bleed to death. There's rarer things, but that are highly associated with cardiac arrests, like amniotic fluid embolism, which is the thought is that you get some elements of like the amniotic fluid or fetal debris into the maternal circulation, and there's like a bad allergic reaction that happens as a result of that leads to heart failure and bleeding.
How prevalent is this?
So there's about, during the time of COVID, there's about 1,200 women in our country who would die a year. But, and you think like that's a really small number compared to the 60 or 70,000.
Diagnosed correctly, that's 1,200.
Yeah, correct. But the number of women who have a severe maternal event, so, things that can lead to cardiac arrest, not necessarily is more along the line of 90,000 women in our country a year. And those women can be left with both short and long-term consequences. So, our course doesn't just teach about the cardiac arrest event. It teaches on recognition of early maternal warning signs and how to prevent that from happening, how to recognize it. And then, unfortunately, if they do go into arrest, it teaches them how to save a woman's life.
Yeah. Is it different, or is it more prominent for like the second child, or is there early indicators that maybe not reach cardiac event through the first pregnancy, but would trigger elevate like a flag, or be a red flag for a second or a third?
Yeah, there's certain conditions you can develop, like preeclampsia, which is a blood pressure kind of systemic vascular condition. that will increase your risk for having seizures. And, ultimately it can result in critical issues. And that is, has a tendency to recur at higher rates in subsequent pregnancies. Certainly if you develop any cardiac event in your initial pregnancy, you're going to be at much higher risk of developing that in subsequent pregnancies. And then just generally speaking, like you're getting older, right? Yeah. And so the chances of developing chronic medical conditions like hypertension, like diabetes, like obesity, continue to increase. So, a patient's first pregnancy may not look at all like their fifth or sixth pregnancy, for example. So,
well, especially because not most of the world isn't as fit as you were saying that
most Americans
constantly. Well, right, definitely most Americans. So probably is even more exacerbated by the sort of average population.
We've got a lot of chronic medical conditions that we're taking care of now in pregnancy, more so than in my 20+ year career. I don't remember the amount of high blood pressure and diabetes.
And there's probably a lot less women smoking. Right?
Yeah, we don't see as many women smoking. That public health campaign has worked. Which is great. It is great, but it's been substituted by all these other
there's plenty of other
things that
vices.
are exacerbated by social determinants of health and lack of access to good food and exercise and sedentary lifestyle, all that.
Is the plan then sort of ultimately to change some of the core curriculum earlier in medical education, or is it continuing medical education seminar? What's what do you see? I figure right. Yes.
No. They're great questions, and the question is like when is it best implemented along a person's educational journey, and to a certain extent you do have to have some knowledge and some experience. Same things with advanced cardiac life support. I mean, there has to be some baseline knowledge. So we did have, for example, second-year medical students who participated who had not done their clinicals yet, and they were actually able to achieve a level of proficiency like our, triple board certified people. So we were happy about that. We had brand new nurses who had just come out of nursing school do it. So I think we can tailor to a lot of different levels. Same thing on the EMS side. We had some paramedic students that took the course, EMS students, some who are just out of training. And so the course is very adaptable to the level of the learner. And in fact, some of our tools and some of our assessment tools are made specifically, for example, for the basic EMT level versus the advanced. And so we had our experts create those in a methodologic way to make sure that, they were appropriately, tailored to those groups. I think we would love to introduce this early on in medical education, but we also want it to be a continuing education. So much like the other courses, you're not just seeing it one time in your career, but you're getting ongoing education and assessment throughout your career.
Yeah, because it feels like all those rare instances that like when you watch the shows on TV and it's like, oh, I read about that when I was a sophomore in medical and pre-med or something, and it's like some rares that
correct
most don't pull disease from that.
I wish I could say this was rare, but it's just unfortunately it's something that we're seeing more and more commonly.
So how do you try and expedite that education and then like adoption of new practices? If it's person to person, either you have an army of trainers or you have to go hospital to hospital?
Correct. Yeah. So in implementation science, once you have guidelines that come out from a national organization, it usually takes 10 to 12 years for it to become standard practice, which should be around now, right? Because that's the American Heart Association's guidelines for cardiac arrest in pregnancy came out in 2015. But unfortunately, we're not seeing that yet. So our plan, and really the reason we developed Varda5 was to commercialize and scale the course so we could get it out to as many communities as possible. And so right now, we are working on a business model that includes both certification and licensing through a train the trainer model.
Yep.
So much like you say, create an army of instructors or faculty to go out there, and really faculty within your own region, within your own local community. So you don't need me to fly out to California to give the course. I've trained somebody, or somebody who I've trained has trained somebody who's able to not only give the courses there, but it's sustainment, right? Sustainability is a really important concept in all this.
So how's it been since like going from like a practitioner to now it's like, okay, I have to develop a business model, and then I have to develop and implement a go-to-market strategy. You're wearing, I mean, those are two different hats, obviously.
I'm still a practitioner.
Yeah.
Still a full-time doctor at UConn. But
yeah, I mean now, but you're also a business owner now.
Yeah, no, I mean it's been with the Summer Accelerator program. I've been learning so much, and I'm so thankful for that. Just learning how to talk business, which my dad and my brother are both business people, so I've been hearing a little bit about it along the way.
You can start using jargon just like them.
Right, exactly. Yeah. They're going to be really
give you all the buzzwords.
Yeah.
What's been like the biggest? I don't know, not shock, but like kind of like, kind of like moment about
aha moment.
Yeah.
For me, it's business is all about relationships. And I guess I never appreciated that as much as I do now, going through this course and talking to the different mentors. And, I think I'm pretty good at adapting and changing and not being scared of that. I think probably most of the people in this course are that way. But just the level of relationship that's needed to advance a business was really eye-opening to me, and I love it. But I guess I just never thought of it. I thought of it more transactional, less personal than what it really is. I mean, it feels like business is run by relationships, and that's something that I think all of us are learning to cultivate more and lean into more. So that was probably my biggest aha.
Well, it is like a different part of our personalities that you have to kind of tap into, and you probably spent time pushing that part down, trying to be a bit more on kind of black and white from a medical standpoint, and taking some of the emotion out of it. So then now to have to recultivate that or let it out, it's probably an interesting dichotomy.
Yeah, I mean, there's a huge relational aspect to the work I do in medicine. It's just different because I think you're seen as the expert. So it's a different type of relationship.
Right, yeah, because you're the authority.
And I mean, in business, to a certain extent, it's that way. But you're actually you're needing to go out and actually get other people's expertise to advance the cause.
You don't as a doctor, you don't necessarily need someone to buy into your diagnosis because you're the expert, right? It's like
typically, yeah.
But when you're
there can be some bargaining and negotiation.
But I mean, when you're, because a lot of what we try to do is understand the problems of a client and then present a diagnosis that we think is the correct solution. But there can be a ton of pushback. They can tell us we're flat out wrong, and so it's it's not necessarily having the authority sometimes that we want when we're presenting, our opinion on the matter. So,
yeah. And there is, I mean, to a certain extent, what I do in pregnancy, it's a captive audience for a short amount of time. And so they're less reluctant to push back or to disagree with you. And much more, like you're saying, they're much more likely to take your word at it and, have faith that you have a medical license, you might know what you're talking about. And business is just different so far. I mean, you don't have those limits necessarily. And so the way to negotiate and bring people to your way of thinking, I think is, like the whole communication piece of it we were learning about today. And I think it's just fascinating, the different facets that you have to tap into that I haven't necessarily been tapping into in medicine.
It's like flexing a new muscle.
Yeah, it's great.
So what are the next steps for Varda5?
Yeah, so we are actually in discussion with a couple of national membership organizations to take this on, to be our partners and to really scale it. I think we need them as much as they need us and our product to get this into the furthest reaches in the United States. And right now, one of my passions is getting it into rural America, because I don't know if you all are aware, but there's been like 800 hospital closures in the last 10 years in rural America. I mean, well, it's about I'm sorry, I'm misspeaking. About 100 hospitals have closed in the last 5 years in rural America, but 800 are at risk for immediately closing. With any, change in federal funding status that might be in the horizon, that is likely to happen. And so Unfortunately, the rate of pregnant and postpartum women dying in rural America is about 3 times that of metropolitan areas right now. And so for me, my passion is getting this into those areas because they really need it.
Yeah.
They really, really need it because there's not a lot of obstetricians left, or what we call maternity care deserts.
Right.
And so getting this education to the people who are actually working in those areas is really critical.
And would these partners also be like funding the expansion and growth of the business?
Yeah, so our buyers are likely to be state EMS directors, as well as in hospitals, the C-suite CNOs, medical directors. And so you don't have to convince them. They know what the problems are. And they're looking desperately for a solution.
Right.
And we're hoping once we get the word out and awareness, it won't take a lot of convincing.
Right.
So you're not necessarily kind of competing with other like educational programs or training programs?
Not really. I mean, we're the only program that exists right now that I'm aware of that has level A evidence. So it's done a randomized trial and proven the effectiveness. And like less than 10% can handle it right now that are currently certified in ACLS, but we got our numbers to over 90%. So the training is very effective.
Yeah.
Well, my question was almost more coming from like the share of wallet, so are they evaluating, well, yeah, this is real and we're not arguing that, our staff needs training, but this over here, impacts 60,000 people and,
Correct, yeah.
120,000 potentially versus, so are they
triaging almost?
Yeah. Of just like, if we have to spend on training for the staff, this module needs to happen before.
Yeah, this one's going to save 1 million lives versus.
Yeah. There is some truth to what you're saying, for sure. I think the thing that motivates them is that there are regulatory requirements, like the Joint Commission requires training in this. And so right now they've been doing out of box their own solutions within their own facilities. Sure. And it's really hard to sustain that because generally it's run by one champion who, if they leave or if they run out of hours to do the training, it becomes very difficult for them to implement these kind of solutions. And so I can tell you, just based on, the talks I've given nationally and kind of running around to different states, we've got a wait list of facilities that want our solutions.
Great. I mean, that's great.
What about like the use of technology to like train practitioners differently? Like, is there a way that they can do it virtually, or does it all have to be in person?
Yeah, so we're looking at those different solutions. There are some of the resuscitation courses that have gone to kind of solo or individual-based training with some unique simulators. Unfortunately, there's not a lot of data that's come out about how effective that is. My only experience was, we had a couple of nurses in one of the states that did that, and that's all they've ever done. They've never done team-based training in their career. They've only done individual, and when they came to the class, they were it was obvious that they'd never done. And they would even tell you, like, oh my gosh, we felt so underprepared for this. And this was so unique. And it's kind of terrifying, right? Because they're certified, but they found it very difficult because they had never worked in that kind of environment. But
is that common?
Watching it happen on a video is a little different than going through
or just going somewhere and having a computer say, okay, now you're going to do chest compressions, now you're going to do valve mask, and we're going to give you a score on the computer, but never kind of doing team-based training. I'm sorry, what was the question?
Is that unique?
Oh yeah, is that unique?
Oh, is that unique?
Yeah.
It's becoming less unique. Yeah, because they save. Otherwise, you have to find time for your people to go do this.
And then pay people
and pay them. Yeah.
But aren't people responding to these events? There's multiple people. There's a team of people. Like,
oh, for sure, yeah. But if you don't know what you don't know, like, so if you've never taken a team-based class,
I just find that kind of odd.
Yeah.
Don't you?
Yeah,
Don't you want to practice like you play?
Not having survey. I bet you that the vast majority of people, if you ask them, would love to participate in, you know, team-based simulations and get more hands-on experience, but they're probably not either getting afforded the time or they're not being compensated or reimbursed or whatever it may be. So
exactly the case.
Yeah. So they can't. So they do what they can. They take an online course and that asks them, okay, what do you do now? And
I accept your explanation.
No, but
I mean, it's not an ideal way,
No.
right? Like, yeah, if I ever have, or, you know, a loved one or anything has a issue, like I would want someone that has boots on the ground training, right?
Yeah, absolutely.
Yeah.
I mean, I was in the military for 15 years. We did a lot of training, of training, and we trained.
I was
and I'm
also
sure,
in the
like, if
military.
you're okay, then you understand. Or if you've ever been on a sports team, that's what you do. You practice so that when you're in the real thing, you know exactly what to do. And it's critical. It's critical in medical issues and medical events because we always say, you know, like this is the place where you can make mistakes. We can correct them, you know, because we don't want you to make mistakes on game day, right? When you're in that event, we want you to run it like a well-oiled machine. We want you to be able to stand up as the person who has the experience, who's taken the course, especially if the people coming in around you haven't, to be able to communicate effectively what needs to happen. And, you know, actually years ago when I was a resident teacher in the Air Force, we had gone through a maternal cardiac arrest simulation and we had a respiratory failure. And I loved it because my first year resident went in there and she had just done this simulation a few days earlier. And the senior resident came in and wanted to do something. And she goes, no, we need to do it right here, right now. And she was absolutely right. And I loved her level of agency as an intern to her chief resident. You know, and I felt like, and when I saw that, I was like, yes, this is exactly why this course works because, you know, we need to empower everyone, nurses, physicians, junior trainees, to step up and do the right thing and make sure their voice is heard. And that's exactly what was occurring in that room. And that chief resident listened to her and they did the right thing. And so that I attribute to team-based training. I don't think that she would have got that if I had just told her to go practice CPR on a mannequin over there in the corner on her own.
It's got to be pretty validating seeing like this starting to be implemented, right? And changes being made.
It's greatly validating, yeah. Especially if, you know, unfortunately I've cared for patients who have died as a result of delayed recognition of conditions. And, you know, those are the most impactful patients you'll ever take care of, obviously, because they have these horrific things happen to them. On the flip side, I've had patients survive because of early recognition. And so to be able to train people to save lives is I don't know what else would give you as much satisfaction in a career.
Yeah, you're rewriting doctrine. It's really cool.
Yeah, I mean, we say it here is like, you know, when people are stressed or unhappy or whatever, it's just like, listen, we're not saving lives here, right? Like the world will continue to turn. Like you are saving lives, so it's a little bit of a different conversation.
Whatever we can do.
We're not selling widgets.
So. But you're getting the word out. That's part of advocacy
we're doing our
too.
part.
Yeah.
But is that so? Relationship gets formalized with these partners. I mean, obviously, that's not like, okay, we're done, right? But like, is that really the sort of juice that you need? You think like that first big push?
Right. Those are our channel partners who have an incredible amount of influence, I think, with people who make the decisions in the C-suites and hospitals and agencies, EMS agencies. So, you know, whenever we do customer discovery with these people, they always ask, well, has anyone endorsed it? You know, and so I think saying that these partners have endorsed it will go a long way. To making this scalable and making it more feasible to get into hospitals. Because right now, I mean, I think a lot of them still think, oh, ACLS is adequate. Then we present the data and they're like, oh, it's really not. Okay, what's the solution here? But, you know, do we really need it? Do we really need to spend the money? Do we, you know, I think it's not hard to get the participants, so the nurses and the docs who take the course become immediate advocates.
Right.
And so we have an army of like 600 people now who have taken the course who become essentially extensions of ourselves in terms of going to their leaders and saying, everybody needs to take this, and this needs to become the national standard. And eventually we'll tip the scales, I think. But we do need those partners, those national partners, I think, in order to do this rapidly. Otherwise, we're just going to do it one person at a time, and it's going to take forever, and we're going to continue to lose lives, and that, in my mind, is unacceptable. Like, we need to do something to turn the tide. I mean, we didn't talk about this, but the United States has the highest maternal mortality rate of any developed nation in the world.
Gotta be kidding me.
It's 2.5 times that. The next one is the UK, actually, but it's 2.5 times the rate of what's happening in the UK.
Lord.
So when you look at those graphs, and the line for the United States continues to go up, whereas the other ones have plateaued or gone down. I mean, it's not acceptable what's going on. So,
I mean, I feel like the U.S. is the lead of those kinds of negative stats in a number of different categories.
Yeah, infant mortality rates started going up for the first time. Yeah, it's not good.
No,
not good.
What do you when you think about growth in the future? What is, in your opinion, the ideal size and scale of your company in order to really attack this problem effectively?
Well, our serviceable market is about 4 million. And so
just here in the U.S.
Just here in the U.S. Yeah. So we would like to get to 80% of that market in the next 5 years. But then we also have global. A global mission, and it depends on where we're going to for that global market. In certain ways, some of the market outside the U.S. might be a little bit easier to penetrate because of standardized healthcare. And pockets of money that are set aside for things like this.
Right.
So we may try to tackle those.
Yeah, I suppose you can go to the NHS, and then it kind of trickles down from there.
Yeah.
As opposed to there's no central governing.
Yeah.
Yeah.
I mean, we actually have a grant work we're doing in Arizona right now. And we chose Arizona specifically because they had what's called regionalized perinatal care. So they have a little bit more of a trickle down effect there.
And so how big of a team do you think you're going to need to kind of tackle the U.S. effectively?
We're going to need a sizable team in every state. Yeah. So it's going to vary based on the state, I think, because of the number
population density.
Yeah, exactly. Population density, number of healthcare workers in each state varies. But I mean, we can be pretty nimble. We're doing a statewide implementation in Vermont right now. We just trained 15 healthcare workers there who are going to go back and start training people within their systems. And we think it's going to take about a year to 2 years to train everyone.
Okay.
But that's kind of what the model we're looking at is trying to get into different regions, train an army within those regions who then go out and are able to provide services locally.
Yeah, you could either have trainers who are on the road constantly, or you could have would you have a brick and mortar kind of location in each state? Would that be the plan?
Not necessarily. I mean, really, if I train, for example, a team of 6 in a hospital, they can turn around and train everybody within that hospital system over time. So they have to have the infrastructure. Right. We just house some of the administrative pieces, giving the certificates out, making sure people register on the website, which will have access to ongoing education and all the instructor materials, update any updates, things like that. So we'll play more of a backseat role. We'll be able to, give consultant hours if that's what they want, things like that, to kind of help them in the implementation process, because we're learning a lot about implementation within different systems.
Is that 4 million replenishing? What's sort of the churn in the industry annually?
Yeah, I mean, so there's probably around 10 to 20% that retire, but then they always get replenished. Well, at least that's the hope. Although if you look at the statistics, we're going to have a need for physicians and advanced practice providers and everything. There's going to be a dearth in 2030. So they're predicting that, there's going to be a gap. But aside from that, I mean, it's pretty steady as it goes in terms of numbers from people retiring and people coming into the system who will need the training. And the lifetime value is pretty long. For a person in medicine, their career spans probably on average 20 to 30 years. So once they're in the system, they'll need refresher training and whatnot. So
yes, that's what I was. So it's I mean, as realistic, but still lofty target, you can kind of look to 3.2 to 3.5 million, trained annually.
Correct. Yep.
In perpetuity.
Yep.
Ideally.
I mean, at that point, so if you train 2 people at the hospital, they can go away and train others, right?
Correct. Yeah.
So
they can, but that's not necessarily business model standpoint.
Well, no, but that's what I was wondering. Do you work yourself out of a
first
job?
person training.
Yeah.
Would probably, it's still,
which would be a good thing.
preferred, I'm sure.
Yeah.
Right. And most practitioners would still need some level of
annual
ACCME training or cert or something, right?
Yeah. So, we're actually studying that right now to see how frequently people need to get recertified. Okay. Right now, the industry standard is every 2 years. With some of our preliminary work, we showed that medical knowledge starts to degrade at around 6 months to 12 months.
Really?
Yeah. And confidence stays high. So it's an interesting quandary.
Don't worry, I've got this.
But getting back to the brass tacks, the people aren't going to want to pay for really a lot of frequent training. So it probably is going to end up being every 2 years, even though it might be every 1 year that people need a bump or a refresher.
Yeah.
But with the industry standard being 2 years, sometimes it's hard to.
Is that different? Is that by state?
That is typically national standard. So for ACLS and basic life support, neonatal resuscitation, pediatric advanced life support, those are all, certification requirements are every 2 years for those courses.
And that differs by medical field or?
Not really, no, not for the ones that require that. So generally speaking, those are the standards for most of the certification courses in medicine is every 2 years.
When it comes to customer acquisition, with hospital systems or otherwise, I'm assuming that it's a lot of outbound, proactive, education. Are you typically doing that at the conferences you were recently at, or what's your mechanism for creating awareness of what you're trying to sell?
Yeah. So a lot of the national conferences I've spoken at, there's a lot of word of mouth. Mm-hmm. Some of our partners have existing relationships with all the hospitals in the country. So another reason why it's really critical, I think, to partner with them is that they already have existing structures of other things they're working on. Mm-hmm. And so it'd be really an easy button to say, use your existing relationships to get this course going within those healthcare systems. EMS is a little bit more tricky because EMS is different in every single state and it's different in every single region.
Because they're governed by counties and towns.
In some states, in other states, they're governed by, a state entity. I mean, it's really, it varies from place to place. And so that is going to be a little bit trickier. And so in our business model, we don't have, we're not as aggressive, I think, in that model as we are in the hospital-based model. Nonetheless, it's still important to us. And there's still, obviously really important considerations because they're the first ones many times to touch these patients.
Yeah.
And sometimes they have long transport times. I mean, some places in Arizona, they're transporting 2 hours with these patients who are critical. So, for us to be able to figure out a strategy to get to, even the places that are locally governed are important. So
that feels like a push, really like a PR tour, right? To get as many conversations as you can at these major conferences and events and, segments on the news would actually get more traction than, sort of the let's go target Northwell this week or group by group. I'm just thinking out loud. It feels like getting you out there talking that this is an issue. This is why you should take notice. And that's really almost all that's needed is that understanding that we might have been doing it wrong or we might be missing something.
Right.
Yeah. And all the Lamaze, I can't remember what they call it in the UK. They don't call it Lamaze.
That's the breathing one. There's other like prepping for.
We call them childbirth education classes.
Yeah.
I know what you're saying.
Sorry.
Lamaze is correct though. I mean, that is teaching you how to breathe.
But I mean, it's like
what to expect when you're expecting.
Yeah. But it's like making, expectant mothers and partners aware early on too. I feel like that's got to be
Yeah,
great
the CDC has the Hear Her campaign, which is all about that. But I'm sure very few people know what the Hear Her campaign is.
I haven't heard.
And that was just about listening to the patient, listening to, what she's trying to tell you, rather than blowing her off and then, having her come in a lot sicker, having her have an untoward event at home.
So what do you think, like, in terms of like ideal future state, like let's say in 5 years, like what do you foresee as like the biggest challenges or barriers you're going to have to overcome in order to get to that like success?
So in our current environment, there's, a lot of defunding considerations for hospital systems, especially academic hospitals that lead a lot of research and a lot of advocacy and awareness around these kind of topics. So I think that's probably the one that, scares me the most. Is what's the impact of, for example, Medicaid funding cuts going to have on initiatives like this? Because hospitals aren't, especially in rural America, like if you take away that kind of funding, they're going to close.
Yeah.
And then, what happens to the patient or the people who live there?
Yeah.
And what happens to the demographic of the family that lives there?
Yeah.
Are they now having to move into cities, and our cities now becoming more populated and more, anyways, so that is, something that we're going to have to contend with I think, down the road. And then just making sure that, for me, something that's really important to me is that the quality of the training is preserved. And sometimes with these types of business models, when you have train the trainer, quality can degrade. And so I really want to play a very active role in making sure that we oversee that and that does not happen. And so what we're doing in the state of Arizona right now is exactly this. We're studying this to make sure that the quality doesn't go down, to make sure that people are still, doing well in their post course testing and really grasping these concepts. So the quality control piece of it is something that, again, kind of scares me a little bit when I talk about scaling. It's something we built and I'm very proud of. But we definitely don't want it to be a watered or diluted version of what we had intended.
Have you thought about what the business ultimately, what it needs to look like in order for it to be your primary focus or your full-time job? Or is it always something that you feel like it's something you're passionate about and something that is the world needs to take notice of, but may never be, your primary?
I wouldn't say it will never be my primary. I intentionally, when I came into the Summer Accelerator program, they asked me that question. And I said, if this takes off, somebody's going to have to, get off the exit ramp. Now I have a partner a business partner who's down in Texas. She's actually willing to leave her clinical job to take over the business. So we have, an immediate solution with her. But if it is that successful, and, the reality is it's like, we're not going to stop at OBLS and Obstetric Life Support. Like, maybe we'll figure out how to make just resuscitation courses in general better. And so I think the sky's the limit in terms of this is the product we're going to start with. But perhaps there's going to be an opportunity to bring in other special populations or other populations and create courses as well. And so I always love new, unique challenges. And I love being a doctor, don't get me wrong. I love, that space too. And I have, people I teach, and I love that part of it. But I also, for me, like my core values are that, the mission of this company is extremely important to me. And if it takes me shifting what my priorities and what I'm doing, I would do it in a heartbeat. Just because your impact can be far greater sometimes.
Sure, yeah. That's what I was wondering, whether, it's tough to talk about something that you're so passionate about as just like the nuts and bolts of business, the economics of business. That's what, I was wondering if you've sort of thought about how those separate, or they're always going to be intertwined, but in this case, if we look toward the event and going through this kind of pitch competition, or just others that may be present, obviously the hope is to bring in angels and private equity and other, businesses that are looking for partners and to network, what would be, if you win or if you're making new connections, what would be the, the one or two things you're just like, if we had this right now, it would help us take the next step?
Yeah, I think one of the things that we are grappling with is the simulation tools that we need to use to scale the course. And so that type of funding would be really helpful to put those kits together. A lot of agencies, especially in rural America, a lot of hospitals in rural America can't afford those things. So like our hospitals around here are large hospitals. Fine. They've got beautiful simulation centers with all the latest technology, all the best simulators. But, if you go down, even to Eastern and Western Connecticut, they can't afford something like that. Right. So either relying on partnering with larger hospitals, but for us, we would love to have these tools to be able to bring up to those hospitals to help them train. And so some of that, just equipment needs, I think we would, if we could get immediately funded for that, that would make a huge difference, because then, that wouldn't be a barrier to training, especially some of these smaller facilities and EMS agencies.
I hope you get all the funding in the world.
Yeah.
I appreciate it.
It feels like you have it's like a no-brainer kind of non-competitive offering, right? It's just a matter of getting it to folks. And it seems like you have the relationships and the contacts in many instances. It's really just the scale now of boots on the ground or equipment, those types of things primarily.
Yeah, it's really fascinating because it's like a case study. And like when I tried to look up and to see how other resuscitation programs have rolled out successfully, there's like nothing in the literature about it. So we're also hoping to, write about this and talk about it. And, there should be a map or a pathway, to not only get this out there, but to keep it successful. And so I feel always sometimes in my field and in what we're doing is I feel like we're the pioneers headed out west.
Yeah.
Trying to figure out the road.
Yeah,
it is pretty cool. Like, so you have to have a lot of grit, right? As perseverance, because, again, roads aren't built and you have to create them. But yeah, I mean, I agree with you wholeheartedly. Like, we have the solution to a problem that a lot of people are grappling with right now. But we need to make it known, and we need to have the right partners, I think, to scale it.
Well, and I think, not to belabor it, but you want to maintain quality control, but also control of the business as long as you can, and not give it away. So you're probably weighing, that, licensing or training the trainer and kind of potentially, making a few bucks every time the course is offered, but it goes out and is now controlled by a AONA or some, some training organization. And there's probably some economic model that you've worked out of when that makes sense or when it doesn't. But
correct.
For this foreseeable future, keeping it and trying to scale it on your own seems like the most prudent for your own pocket.
Yeah, I think again, if we go on our own, the scale is gonna be smaller, and the ability to get the reach out is gonna take longer. Yep. As we build the business out, and so I think that we can figure out a win-win-win for everyone involved, and that's kind of what I would like to do to try to scale it quickly.
Yep.
Yeah, because it's not like. It's like, oh, we're going to build slower, do it more organically. And, we may make, not as much revenues. It's like the slower you go, the more people die, and like that is never an issue for 99.9% of business owners, right? It's only limited to revenue, but lives are literally at stake. So,
well, we appreciate your time. Thank you for coming.
I loved being here and being your guest. Thank you.
Oh, well, we appreciate it.